So health disparities has thankfully become placed into the spotlight of what we do in medicine. Obviously, I'm a bit interested in this, both personally and professionally, as an African American man, but also as someone who does a lot of work in this field. And although we often think of these things as maybe being specific to the US, there are equivalents of this really around the planet. The reality is that the data is striking. So here in the United States, we know, for example, that those of us of African descent are twice as common. It is twice as common to have the diagnosis of myeloma. And that really is an international phenomenon, not just here in the US. But the sad reality is that the average survival of a Black man or a Black woman with myeloma is half that of a white man or a white woman with myeloma of the same age. And that's really mitigated by a whole series of factors. And we sought to outline this in the papers that we've been working on, the initiatives that we've been addressing. It really has a multifold complexity that I'll just quickly summarize to say that there are systemic phenomena within the society, whether it be systemic racism, lack of trust within the healthcare system. Indeed, secondly, the healthcare system itself and the way the insurance is built here does sadly lead to a greater disparity. And then there are those social determinants of health that we know just affect all of us, socioeconomic status, access to the basics of life. So with those three as sort of the basic societal, healthcare, and economic realities, then there are myeloma-specific reasons for why the disparity is so great, primarily in two major areas: the delayed diagnosis. So we know that the average patient takes 3 visits with their primary care before, with signs and symptoms consistent with myeloma, before the diagnosis is suspected and confirmed. That's even longer in African Americans and in Latino and Hispanic Americans, often because of lack of access to the system, but also confounding diagnoses like diabetes. And then the second major area is access to these great therapies that we have. And in fact, I often argue that we have 4 different waves of therapy that have so influenced survival in myeloma, and they all start with the letter T: triplets or 3 drug combinations, transplants or autologous stem cell transplant, clinical trials, and more recently, CAR T-cell therapy. And sadly, we've demonstrated that in all 4, there's been reduced access for certain populations, namely the African American and Latino American populations. So the stats are rather grim. On the other hand, there's a lot of work being done to overcome this, to build greater inherent trust in the system, to have us recognize the deficiencies within the healthcare system, for us to address the social determinants of health and not just the disease, as it were, and then to work very hard to educate our primary care colleagues to reduce the time to diagnosis, and then work within the myeloma-specific sphere to enhance access to care. And so I've had the privilege as the Chief Medical Officer of the International Myeloma Foundation to lead our Empower initiative, which is really designed to improve the short and long-term outcomes of patients that have historically been underrepresented in myeloma. So there's a lot of work to be done, but I think we have a blueprint of how we can do this. And it really requires tremendous collaboration across the medical and the non-medical system to raise awareness of these issues and to address them specifically.